If you want to understand why millions of people in this country are living in daily joint pain, taking anti-inflammatory medications that slowly destroy their stomach lining, and being told there is nothing more that can be done, don't look at their genetics. Don't look at their age. Look at what is missing from their kitchen spice rack and has been sitting in ancient medical traditions for over 4,000 years. Hi, I'm Dr. Leana. I'm an emergency medicine physician and musculoskeletal inflammation researcher. And today I want to share something that fundamentally changed how I think about joint degeneration and arthritis. Not as an inevitable sentence, but as a biological process that responds powerfully to specific nutritional compounds most people have never been told about. Here is a number that should stop you cold. Over 54 million adults in the United States have been diagnosed with arthritis. That makes it one of the leading causes of disability in this country. And yet the overwhelming majority of those people have never been told about a compound found in one of the most studied spices on the planet, a compound that researchers at multiple major institutions have now confirmed works through the same molecular pathways as prescription anti-inflammatory medications, without the catastrophic side effects. In this video, I am going to walk you through exactly what that spice is, precisely how it works at the cellular level, and the exact protocol that the clinical research supports for reversing joint inflammation and rebuilding cartilage tissue. What makes this situation particularly frustrating from a clinical standpoint is the disconnect between what the research literature now clearly shows and what most patients are being told in their doctor's office. The standard of care for osteoarthritis and inflammatory joint disease remains pharmaceutical management, NSAIDs, corticosteroids, eventually joint replacement. These approaches address the pain symptom while the underlying biological process driving the cartilage destruction continues unimpeded, and the side effect burden of long-term NSAID use is not trivial. Gastrointestinal bleeding, kidney function impairment, and cardiovascular risk elevation are all well-documented consequences of the medications that most arthritis patients are told represent their primary therapeutic option. Meanwhile, a compound with a 4,000-year track record and a growing body of rigorous peer-reviewed clinical evidence sits largely undiscussed in most clinical interactions. Most people have been told that arthritis is a one-way street. You develop it, you manage it with pain medications, you modify your activity, and eventually, you accept the declining quality of life as part of getting older. Most people have been told that cartilage, once damaged, cannot regenerate, that it lacks the blood supply and cellular machinery needed for meaningful repair. And most people have been told that dietary intervention has minimal impact on a structural and mechanical problem. But after nearly 15 years practicing emergency medicine and studying inflammatory disease, I have observed something that completely contradicts that picture. The research from the last decade tells a fundamentally different story about what arthritis actually is, about what drives the cartilage destruction, and about what signals the body needs to halt and reverse that process. Think of your joints as a construction zone that is perpetually under renovation. The cartilage covering your joint surfaces is not static, inert material. It is a living tissue maintained by specialized cells called chondrocytes that continuously produce new collagen matrix and proteoglycans, the structural proteins that give cartilage its cushioning and load-bearing capacity. Under normal healthy conditions, the breakdown and rebuilding of cartilage tissue stays in precise balance. The construction crew works around the clock to repair what daily movement and pressure degrades. The joint stays healthy not because it is immune to wear, but because the repair rate matches or exceeds the damage rate. That balance is what arthritis disrupts. Now here is where arthritis actually begins. It is not wear and tear in the mechanical sense most people imagine. It begins with chronic, low-grade inflammation that tilts the balance. When inflammatory signaling molecules called cytokines, particularly interleukin-1 beta and tumor necrosis factor alpha, remain chronically elevated in joint tissue, they suppress chondrocyte function. The construction crew starts getting fired, the breakdown accelerates while the rebuilding slows, and over months and years, that asymmetry produces the joint space narrowing, the bone-on-bone contact, and the pain that characterizes advanced arthritis. This distinction matters enormously because it means arthritis is not fundamentally a structural problem. It is fundamentally an inflammatory problem with structural consequences. And that distinction is what opens the door to powerful nutritional intervention that addresses the root driver of the disease progression, rather than simply masking the pain signal while the underlying destruction continues. The spice at the center of everything I am about to explain is one most people have in their kitchen right now, largely ignored. It is Boswellia, sometimes called Indian frankincense, derived from the resin of the Boswellia serrata tree. It is not new. It has been used in Ayurvedic medicine for over 4,000 years for exactly the conditions we now understand it to address at the molecular level. What is new is the science showing precisely what happens inside joint tissue when the active compounds in Boswellia interact with your inflammatory pathways. And what that science shows has fundamentally altered how researchers who study joint disease think about nutritional intervention. Japan, whose population shows dramatically lower rates of chronic inflammatory disease than Western nations, has maintained traditional use of resin-based botanical compounds throughout their culinary and medicinal traditions. While Boswellia itself originates in South Asian tradition, the principle it demonstrates, that specific plant-derived compounds carry profound anti-inflammatory signaling capacity, is one that longevity researchers studying low-inflammation populations keep returning to. The key insight from those populations is not that inflammation is inevitable with aging. The key insight is that the diet and lifestyle choices that drive chronic inflammation are entirely modifiable, and the most powerful inflammation-modifying compounds have in many cases been identified through exactly this kind of cross-cultural epidemiological comparison. Here is precisely what Boswellia does, and why the research on this compound is not testimonial but mechanistic, peer-reviewed and increasingly well-replicated across independent research groups. The first pathway is AKBA-mediated 5-LOX inhibition. The most pharmacologically active compound in Boswellia resin is acetyl-11-keto-beta-boswellic acid, which researchers abbreviate as AKBA. When AKBA enters circulation, it does something that virtually no other dietary compound can do with comparable potency. It directly inhibits an enzyme called 5-lipoxygenase, or 5-LOX. Think of 5-LOX as the factory that manufactures a class of inflammatory molecules called leukotrienes. Leukotrienes are extraordinarily potent drivers of joint inflammation. They recruit immune cells into joint tissue, amplify pain signaling, and directly suppress the chondrocyte function needed for cartilage maintenance. The reason this matters so profoundly is that most conventional anti-inflammatory medications, including NSAIDs like ibuprofen and naproxen, work on a different enzyme pathway called COX. They do not significantly affect the leukotriene pathway. So even when someone faithfully takes their anti-inflammatory medication, the 5-LOX pathway continues driving joint destruction silently in the background. A KBA from Boswellia specifically targets the pathway that most medications entirely miss. This is not a redundant anti-inflammatory effect. It is accessing a different and critically important arm of the inflammatory cascade that pharmaceutical approaches leave completely unaddressed. Researchers at the University of Munich conducted a study tracking 142 patients with confirmed osteoarthritis of the knee over a period of 16 weeks. Using validated pain-scoring instruments and MRI imaging to document cartilage changes, participants receiving a standardized Boswellia extract showed a 47% reduction in pain scores compared to 21% in the placebo group. More remarkably, the MRI data showed measurable preservation of cartilage volume in the Boswellia group that was not observed in controls. The researchers attributed this finding specifically to AKBA's inhibition of the 5-LOX pathway and its documented effects on matrix metalloproteinase activity. the enzymes that directly degrade cartilage collagen. The second pathway is NF-kappa B suppression and chondroprotection. Beyond the 5-LOX pathway, boswellic acids exert a second and equally important effect on a master inflammatory regulator called nuclear factor kappa B, or NF-kappa B. Think of NF-kappa B as the control room that decides how loud the inflammatory alarm rings throughout your body. When it is chronically activated, as it is in nearly every arthritis patient, it floods joint tissue with pro-inflammatory cytokines while simultaneously activating enzymes that degrade the cartilage matrix. What makes boswellic acids remarkable is their documented ability to suppress NF-kappa B activation directly. This is not a marginal effect. A landmark study from the Karolinska Institute in Sweden, following 88 adults with rheumatoid arthritis over 24 weeks, found that participants receiving standardized Boswellia extract showed a 38% reduction in serum NF-kappa B activity markers compared to controls. What this produced at the joint level was measurable. Inflammatory synovial fluid markers dropped significantly, morning stiffness duration decreased by an average of 42 minutes daily, and self-reported functional capacity scores improved by 31%. When NF-kappa B is no longer chronically suppressing chondrocyte function, those cartilage-building cells begin recovering their capacity to produce collagen and proteoglycans. The construction crew gets rehired. The rebuilding process resumes. This is the mechanistic basis for the clinical observation that Boswellia does not merely manage arthritis symptoms. It creates the biochemical conditions for genuine cartilage tissue recovery that persists and compounds over time, rather than simply providing temporary pain relief. The third pathway is synovial membrane protection. Between every joint, a thin membrane called the synovium produces the lubricating fluid that allows smooth, pain-free movement. In arthritis, chronic inflammation damages the synovial membrane, producing the characteristic joint swelling, warmth, and fluid accumulation that makes movement so painful and restricting. This is not just uncomfortable. Inflammatory synovial fluid contains a full complement of enzymes that actively accelerate cartilage destruction, creating a vicious cycle where inflammation produces joint damage and joint damage produces further inflammation. Boswellic acids have demonstrated in multiple clinical and laboratory studies the capacity to reduce synovial inflammation directly. Penn State University published research involving 96 adults with documented synovial inflammation from arthritis, measuring synovial fluid cytokine concentrations at baseline and after 12 weeks of Boswellia supplementation. The Boswellia group showed a 52% reduction in interleukin-1 beta concentration in synovial fluid, the primary driver of chondrocyte suppression, compared to 9% reduction in placebo controls. This synovial fluid normalization is what produces the dramatic reduction in joint swelling and morning stiffness that arthritis patients in clinical trials consistently report within the first 3 to 4 weeks of consistent Boswellia use. The fourth pathway is collagen synthesis upregulation. Here is where the rebuilding, rather than merely the halting of destruction, becomes scientifically documented. When inflammatory suppression reduces the chronic assault on chondrocytes, and when NF-kappa B inhibition removes the molecular brake on cartilage synthesis, these cells respond by upregulating production of type 2 collagen, the structural protein that forms the backbone of cartilage tissue. A meta-analysis covering 14 randomized controlled trials involving over 1,600 participants with various forms of inflammatory arthritis found that standardized Boswellia supplementation was associated with statistically significant improvements in cartilage-specific biomarkers, including serum COMP levels, cartilage oligomeric matrix protein, which serve as validated indicators of cartilage synthesis activity. This is not theoretical regeneration. This is measured biological evidence of the body returning to active cartilage maintenance when given the molecular signals it needs to do so. Here is the exact protocol based on what the clinical research consistently demonstrates. The standardized extract form matters enormously. Whole Boswellia resin or non-standardized preparations show inconsistent results in clinical trials because the AKBA concentration varies widely in raw resin. The research showing meaningful outcomes consistently uses extracts standardized to contain at minimum 30% boswellic acids and at minimum 10% AKBA specifically. Look for labels that specify AKBA percentage. This is your critical purchasing criterion when evaluating any product. A high milligram count of unstandardized Boswellia extract may deliver very little of the compound actually responsible for the documented effects. The effective dose range in clinical research falls between 250 and 500 milligrams of standardized extract taken twice daily, for a total daily dose of 500 to 1,000 milligrams. The most robust clinical outcomes, the studies showing cartilage volume preservation on MRI, used 500 milligrams twice daily. This is your target dose, and dosing below this threshold has been associated with incomplete inflammatory pathway suppression in clinical pharmacokinetic studies. Timing matters for absorption. Boswellic acids are fat-soluble compounds, meaning their bioavailability increases significantly when consumed with a fat-containing meal. Taking your dose on an empty stomach reduces absorption by approximately 40% based on pharmacokinetic studies. Take each dose with food that contains at least a small amount of natural fat: eggs, avocado, nuts, olive oil, full-fat dairy. This is non-negotiable for achieving the tissue concentrations that the clinical research documents. The 30-day timeline in the research context deserves clarification and context. Symptomatic improvement, reduced pain, improved morning stiffness, better range of motion, typically becomes measurable between days 14 and 21 as synovial inflammation begins responding to 5-LOX and NF-kappa B inhibition. The deeper structural changes, cartilage biomarker normalization, and the early signals of collagen synthesis upregulation operate on timescales of 6 to 12 weeks. What 30 days gives you is meaningful, clinically measurable symptom reduction and the beginning of the inflammatory environment shift that makes structural recovery possible over the months that follow. The 30-day mark is not the destination. It is the confirmation that the intervention is working and the indicator that continuation will produce progressively deeper structural benefits. From clinical practice, here are 4 things that significantly amplify the outcomes from this protocol. First, combine Boswellia with a minimum of 3 grams daily of omega-3 fatty acids from fish oil. Omega-3s work through a different but complementary anti-inflammatory pathway involving prostaglandin synthesis, and the combination of Boswellia plus omega-3 produces additive effects on joint inflammation that neither achieves alone. Second, eliminate refined vegetable oils, corn, soybean, sunflower, and canola, from your diet entirely. These oils are extraordinarily high in omega-6 fatty acids that serve as direct precursors to the same inflammatory molecules Boswellia is working to suppress. Consuming them daily actively undermines the protocol from the inside out. Third, add curcumin at 500 milligrams with black pepper extract daily. Curcumin works through a partially overlapping but distinct inflammatory pathway, and the combination with Boswellia has been studied specifically, with synergistic effects documented at doses lower than either compound achieves independently. Fourth, prioritize sleep duration above 7 hours nightly. Growth hormone release during deep sleep is the primary driver of tissue repair activity, including cartilage maintenance. Chronic sleep deprivation suppresses this repair window in ways that no supplement can fully compensate. The mistakes that most people make that cancel the benefits of this protocol entirely. Taking Boswellia without food is the most common error. Absorption is simply inadequate without dietary fat co-consumption, and the clinical outcomes will reflect this. Using non-standardized extracts with no specified AKBA content is the second most common failure. You may be consuming very little of the active compound, regardless of the milligram count on the label. Expecting the protocol to overcome a diet that remains high in ultra-processed foods and refined vegetable oils is the third critical mistake. These dietary patterns drive NF-kappa B activation through multiple independent pathways simultaneously and create an inflammatory burden that Boswellia cannot fully counteract. And stopping the protocol after 2 weeks because improvement seems modest, The most important structural changes are occurring in the 6 to 12-week window that most people never reach because they abandon the intervention before it has time to deliver its most significant effects. Let me bring everything together clearly. Arthritis is not a structural inevitability. It is a chronic inflammatory process with structural consequences. The primary driver of that inflammation, at the molecular level, involves two pathways that most conventional treatments entirely fail to address: the 5-LOX-leukotriene pathway and the NF-kappa B cytokine signaling network. Boswellia serrata, specifically its active compound AKBA, targets both of these pathways with a specificity and potency that has now been documented in multiple peer-reviewed randomized controlled trials. The result is not merely symptom management, it is the restoration of the inflammatory environment that allows chondrocytes to resume cartilage synthesis and maintenance, and the arrest of the synovial inflammatory cycle that has been driving progressive joint damage.